And welcome to the Renal Association COVID-19 webinar. I'm Indranil Dasgupta. I will moderate the session. Technology permitting, I'm looking forward to an exciting session. As you know, we are probably past the peak of COVID-19 epidemic in the UK. And so it is a good time to take stock of our collective experience in the renal community and of learning that might be applied should there be a phase 2. As for the format of this webinar, we have 5 short presentations to start with, covering broadly AKI, transplantation, dialysis, and research. To be delivered by 5 eminent nephrologists, and this will be followed by a question and answer session. The panel will comprise our 5 speakers, and they will be joined by Fiona Loud, Policy Director, Kidney Care UK, and a transplant patient herself, and Karen Jenkins, President of AN UK and Consultant Renal Nurse in Canterbury. So please use your question answer function on your screen to submit questions, which I will then forward to the panel. Without further ado, let's start the presentation. The first topic is AKI, which will be covered by 2 speakers, both from London. And as we know, London saw the highest number of COVID-19 cases and COVID AKI. And hence our speakers have significant experience of dealing with COVID AKI, both in ICU and on the ward. So our first speaker is Chris Lang from Royal Free. Chris is a consultant nephrologist and is also an expert in acute kidney injury. Chris is a divisional Clinical Director of Emergency Services at UCLH.
So thank you very much, Indranil and the Renal Association, for the kind opportunity to speak. My name is Chris Lang. I'm a consultant nephrologist at the Royal Free in UCLH, and I'm here to do the first half of the AKI section with Claire. So I'm going to talk a little bit about AKI more generally, and Claire is going to be speaking about the more renal unit specific experience and renal support issues that she's been experiencing in King's. So I'll, in terms of the scale of the problem, we've just done an evidence review for NICE, and from the published literature, much of it from China, we are seeing an quite a variable incident rate of AKI across all stages. In some reports, 0, doesn't get much lower, all the way up to 27%. I think broadly it's fair to say that the AKI incident rates are similar to an acute hospitalized cohort. And in my organization in UCLH is sitting at around 17%, much of it self-limiting. There is evidence from the literature and our local experience that the AKI incidence is higher when markers of illness severity are higher. And these may be laboratory, CRP, neutrophil count, D-dimer, or physiological, such as News score. I'd say in our higher News scores, moderate to severe News scores, or CPAP cohort, we're seeing an AKI incident rate of around 40%. The evolution of this illness, many illnesses which present in the community and are managed in hospital, we tend to see AKI at the start of the illness, but I think what we're seeing a lot of with this illness is AKI that evolves during the hospitalized stay or indeed during critical care. And this is some local data, snapshot of 30 patients. And we can see here, this is time from to AKI from symptom onset of COVID. And this is 16 days with hemofiltration 17.5 days. So I think we're seeing a delayed onset of AKI following hospitalization of in some COVID patients. And indeed, this appears to differ from some other acute infections which present at the front door. If one just looks at the intensive care national audit data, this is ICNARC. They've been releasing weekly returns on the situation in AKI and critical care. We are seeing renal support rates currently of 23% in the critical care cohort, and this compares to 17.9% in patients with other viral pneumonias. This is almost exclusively in tandem with respiratory support. Isolated renal support being delivered in critical care in COVID patients is only 1.1% of the COVID critical care cohort, in fact less than those for other viral pneumonias. What are the clinical characteristics? Well, from the literature, the published literature, and our local experience, we're seeing oliguria or polyuric, but generally oliguric AKI. We're seeing hypokalemia, much more hypokalemia than we would normally expect, and this may represent tubular damage, as I'll discuss, or indeed a hyperreninemic state. But we are seeing hyperkalemia as one would expect in severe forms of AKI. A reasonable instance of hypophosphatemia, hypo or hypernatremia, generally hyponatremia, which may be hypovolemic. There are high amounts, 40 to 50% in some series of abnormal urinalysis, blood and protein on urine dipstick, and this appears to occur in patients also who don't have AKI. We are seeing disproportionate high chloride normal iron gap acidosis. We are not seeing true TMA systemic markers such as low haptoglobins, etc., nor have we yet seen reports of renal vein thrombosis or vascular thrombosis, though clearly there's reports of thrombotic events in other organs. We are seeing high CRP, high neutrophils, low albumin, high D-dimer, and leukopenia, and usually other COVID illness in AKI, as I've discussed, so pneumonia and microvascular thrombosis of other organs. So in general, the patients that I'm seeing in critical care are those who are most ill with COVID-19, most of whom are on respiratory support. What is the causation? Well, clearly a large component of this is multi-organ failure with critical illness, a form of cytokine storm. There has been a great deal of discussion whether in some centres where a dry strategy maintain sort of targeting hypovolemia to reduce the risk of ARDS or fluid in the lungs might be an issue. And indeed, the PEEP or mean airway pressure that is delivered through CPAP or invasive respiratory support. PEEP has been shown to cause lower cardiac output and high renal vein pressure. It has not been shown in the literature that high PEEP rates in any context are an independent risk factor for AKI, but these factors may have been in play or contributory. I'd certainly say they're not the whole story. There is now post-mortem data showing acute tubular damage, lymphocyte and macrophage infiltration of tubules, and we're seeing immunohistochemistry evidence of the COVID-19 antigen in tubules and the virus in renal tissue. It does bind to ACE2, which is on the proximal tubule brush border. It may be invading through podocytes, being filtered, and then binding with proximal tubules. So there appears to be direct invasion of kidney, particularly affecting tubules. But we're also seeing collapsing glomerulopathy, which we would normally see in other viral illnesses, particularly HIV, renal edema. I'm certainly seeing patients who have a secondary AKI due to bacterial sepsis on ITU as a secondary event. So what are the outcomes? Well, with any renal support, the outcomes are poor. So a 74.8 mortality from last week's cut. When there is advanced renal and respiratory support, it is similar. When there is advanced respiratory, cardiovascular and renal supports, that's inotropes, ventilation and CRRT, we're seeing an 83.4% mortality. For the non-ITU renal support cohort, we are seeing an adverse impact on survival, a 5 times hazard ratio, with increasing mortality associated with AKI stage. I think CKD risk, we know this is 15% for all AKI at 1 year, but I think a little early to say what the CKD burden will be of this disease for those who have survived. In terms of specific management considerations in tubular injury, we are certainly seeing some proximal tubular defects resulting in Fanconi syndrome. We'll see salt and water, potassium bicarbonate, phosphate wasting. We'll see hypovolemia, hypokalemia, hypophosphatemia, and a hyperchloremic acidosis. On investigations from urine, we would see retinol binding protein glycosuria, an elevated protein creatinine ratio with normal albustics, and inappropriate measured phosphate or potassium excretion on spot urine. This may only manifest when GFR is restored after the initial renal injury, and there's a filtration into the tubules which then wastes. So it may be a delayed phenomenon, and therapy is entirely replacement therapy with bicarbonate, saline, potassium, or phosphate pending tubular healing. And with that, I'll conclude.
Thanks very much, Chris. Our next speaker is Professor Claire Sharp. Claire is Professor of Nephrology at King's College London. And Claire will also present on COVID-19 AKI. And she's got significant experience of working in ITU and at King's. So Claire, over to you now.
Thank you, Indy, and thank you, Chris, for that great introduction. So it was only 11 weeks ago that we had the first report of person-to-person transmission of the SARS-CoV-2 virus in the UK, which isn't that long ago when you consider what we've been through since then. But at that time, what I as a nephrologist was most worried about is what the impact of this disease was going to have on our dialysis and transplant patients who we considered to be the most vulnerable patients. And there were reports coming out of China, such as this one, which told us that AKI wasn't a particular problem. So it gave us a kind of sense, really a false sense of security. But perhaps what's more informative was another paper that came out of Wuhan over the same time period with a much larger cohort. That although AKI still wasn't common in that cohort, only 5.1% of patients developed AKI, it did give us this early warning that it was a bad prognostic marker, and that of those patients that developed AKI, their cumulative death rate over 25 days was 75%. So Chris has already mentioned the Intensive Care National Audit Research Centre data that's been reporting since the middle of March and is reported on all intensive care units across England, Wales and Northern Ireland weekly. And I've used that data to draw this graph so that you can see what's been happening to patients who have full outcomes on ICU and how many of them have needed renal replacement therapy since the 20th of March. So these are only patients that have completed their ICU stay, so they've either been discharged or they've died. And you can see how the rate of renal replacement therapy has been increasing. Overall, it works out about 23%, but actually this has varied hugely from region to region, with some hospitals having only 5% and other hospitals having as much as 75% of their patients on RRT. And it became apparent that because we were having more AKI, that this wasn't just an issue in the UK, but it was also an issue in the US at the same time. And the need for renal replacement therapy was going to cause a significant problem in the supply of both filters and the consumables for RRT. On the 15th of April, NHS England, having realised this, released this document to help us try and minimise the use of RRT on ICU. And they advocated that loop diuretics should be used for fluid overloaded patients, and that we should consider using potassium binders and bicarbonate in order to try and maximise the use of medical management before putting patients on RRT only for life-threatening complications. Also in that document, they pulled out the potential ways we could give renal replacement therapy to our patients. You can see from this table, the conventional forms of renal replacement therapy are on the left, the continuous forms of hemodiafiltration, which we're used to using in the intensive care unit. They also suggested that we could use intermittent forms of hemodialysis, albeit modified, but we know we need to use have infrastructure in our ICUs to use this, so you have to have a reverse osmosis machines. But they also suggested in that document that we should consider using peritoneal dialysis as a low-tech form of renal replacement therapy in ICU. So at King's College Hospital, we were particularly hard hit. By 26th of April, we had admitted 147 patients to ICU with COVID pneumonia, and 80 of those patients required renal replacement therapy. We are very experienced in delivering peritoneal dialysis to our chronic outpatients, and we've also used it intermittently to treat patients with AKI, but we've only rarely used it in the intensive care setting beforehand. However, when it became apparent at the end of March that we were really going to be struggling at King's College Hospital, we instigated PD in ICU. We used our normal protocol, which our team is run by a clinical nurse specialist who inserts the peritoneal dialysis tubes under local anaesthetic. And in these patients, we put them on automated PD immediately after inserting the tube. Most people are concerned about peritoneal dialysis in patients who are ventilated because of the risk of splinting of the diaphragm and affecting their ventilation. But as you can see from these data, the arterial oxygen to FiO2 ratio didn't alter between the day before starting peritoneal dialysis and the day after peritoneal dialysis, suggesting that we weren't impinging on their ventilation. And also their sequential organ failure assessment, which is a score of how unwell they are, wasn't changed by starting the PD in these patients. And neither was the need for vasopressors. So we were quite confident. This is on our first 31 patients that we started between 31st of March and the 26th of April, that delivering peritoneal dialysis was safe. We then looked at whether it was effective. And the other parameters that we're most interested in are hyperkalemia and acidosis. I haven't put up anything here for fluid removal because many of these patients, as Chris has pointed out, were dehydrated. And so we weren't actually removing a lot of fluid from them. But in those patients that were fluid overloaded, ultrafiltration worked perfectly well. And you can see here on the left that we were able to control hyperkalemia and reduce acidosis quite effectively. So thankfully now, looking back at the IGNART data, this is from the latest report, the number of admissions of patients to ICU is reducing, so is the number of patients with renal replacement therapy. So hopefully we're over the worst of this, but we will be prepared if there is a second wave. We've got the experience now and we can go back in and do PD. And I'll just leave there and thank Hugh and Elaine who run the PD service. Thank you.
Our next presenter is Gareth Jones. Gareth is a transplant nephrologist at Royal Free Hospital, London. He was instrumental in producing the Pan-London COVID-19 guidance on management of kidney transplant patients, which was endorsed by the Renal Association and has been used or followed widely in the UK. So Gareth, over to you now.
Good. So these are my disclosures for the statisticians in the audience. So I really wanted to paint a picture of what the pandemic meant to us, what happened during the pandemic. This graph shows the bed utilization at the Royal Free, the general bed utilization in blue here, not including ITU, and the ITU bed utilization along the bottom. And as you can see, early on in March, we got hit quite hard. At the point around about the 24th, we had to close our program because the number of admissions had gone exponential. And the day before, we had admitted 75 patients to the hospital with COVID, and it was becoming increasingly difficult to separate the COVID from the non-COVID patients. That bed utilization peaked at about 360 beds in early April and has then been falling off since. From the ITU point of view, there was a rise in early March, and then this stubborn plateau. Yes, there is some turnover here, but this also gives you an indication of the long-term weaning of these patients. What did this mean to national transplantation? This is some data from NHSBT showing the number of renal transplant units that were open for transplantation over time. And I put a couple of time points in here when the UK reached 2,000 cases and also at shielding. And at the point of shielding that was in the 3rd week of March, there was quite a rapid drop-off in the number of units that were undertaking kidney transplantation, partly because there was the difficulty of separating COVID from non-COVID on transplant units, but also as resources were turned to looking after COVID patients. That hit a nadir down here in early April, and then there's been a rise with more units opening up since. I was asked to mention something on recovery. What does recovery look like? Well, this is highlighted in the ODT document that's listed below, and it starts with agreement, making sure that you have got the resources back that were redeployed, making sure that you have safe areas to undertake transplant and their follow-up, putting in place your screening protocols, evaluating your waiting list, who you wish to transplant during a COVID pandemic, and then setting your donor limits before reopening your unit. This was the point that I was really asked to focus on during this talk. How can we justify transplanting people during a COVID pandemic? Well, I've taken one of my teaching slides. This is data that I've taken from the UK Renal Registry, and then compared it to some data from Cancer Research UK, looking at the survival of breast cancer. And the point that I make to the medical students is, if you look at the survival on dialysis compared with breast cancer, there's a roughly double mortality for the patients on dialysis compared with breast cancer. What I've then done is layered on top the green line here, which is NHSBT data of the survival on the waiting list, and then the survival post-deceased donor transplant, and the survival post-live donor transplant. And the point that I make is this really is our chemotherapy. And if the oncologist had a chemotherapy that could add an additional 20% survival at 10 years, or even better, a 30% survival at 10 years, they would be kicking down the doors of Parliament to get hold of that. So how is this relevant to COVID? Well, this risk balance benefit has not changed because there is a virus around. The only difference is you then have to balance that risk of the COVID on top of that. In addition, I'd make you stop and think and say, well, if you had cancer now and you needed chemotherapy that made this much difference to your outcome, would you want to be treated during a COVID pandemic? This is something that drove us really from the very start of looking at the relative risk of getting COVID during a pandemic. This is the cumulative number of confirmed cases of COVID at the Royal Free in our hemodialysis population at the top, compared with our transplant population at the bottom. And for every one transplant patient that had confirmed COVID and required admission, there were 7 hemodialysis patients. And one of the ideas was that you could try and take the transplanted patients out of that risk of developing COVID. What did that mean to them? Well, when we went into this pandemic, we had 764 hemodialysis patients and 1,400 kidney transplant patients followed up at the Royal Free. If you look at this is confirmed cases, 18.5% of our hemodialysis population had confirmed COVID, with 27% with confirmed and suspected. This is the mortality. We've lost 5.2% of our hemodialysis population during this time. If you then compare it with transplantation, only 1.5% of the transplant population got COVID, and we only lost 0.3%. Are these two groups comparable? Maybe not, but we do have quite a mature transplant population. Could you look at the waiting list patients? Well, when you look at our waiting list patients here, 7% developed COVID, and we had a mortality of 0.4%. But before everyone rushes back to open up their transplant program, there is a salient message from the Wessex Centre, and I'm really grateful to Keith Grates for giving me this data. This is their last 7 kidney transplants that they undertook in the centre. All 7 developed COVID-19, 2 of which died. 1 was ventilated and still is ventilated in ITU and has had their kidney removed. 1 has had a transplant nephrectomy and gone home. 2 were discharged home after a long stay, and 1 managed as an outpatient. So this gives you an insight into what can happen when COVID gets into your unit. Where am I going to finish? I'm going to finish here, and hopefully this segues into the next speaker. This was something that our Tottenham Hale Kidney Care Centre staff sent to us to say thank you. During the bank holiday weekend, 75% of our hemodialysis staff had COVID and were in isolation. We dialysed 250 patients in Tottenham Hale. We were going into the weekend not knowing whether we could dialyse those patients. So up stepped every single nurse that had ever used a dialysis machine in anger. The consultant nephrologist came along to clean beds, line and prime machines, and our transplant surgeons came along to needle fistulas to get patients on dialysis. And we got through that weekend and the following week. They then wanted to say thank you to us, but I want to send this out to everyone to say thank you for looking after all the kidney patients in what has been a very difficult time. Thank you. I'll stop there.
Our next speaker is James Metcalf, Professor James Metcalf. He's a consultant nephrologist in Leicester and the medical director of the UK Renal Registry. James has been coordinating and has been playing a huge role in the registry weekly COVID-19 registry report that we've been receiving for the past few weeks rather. So James is going to talk about how COVID-19 has affected our kidney patients. James.
Thank you, Indy. So in the interest of time, I was just going to dive straight in and outline the 4 areas that I wanted to cover in my 8 minutes. I'm going to remind people a little bit about the source of the data that I'm going to talk about. I'm going to talk about some summaries of the weekly data that we've been reporting over the last 5 weeks. I'm going to share with you some analysis that was looking at the risk factors across the population in general. And then towards the end, I just want to outline the future plans of the renal registry, particularly with regard data linkage, swabbing behaviours and practice patterns. So just starting with the source of the data, back at the beginning of the pandemic, the renal registry asked the renal units in England, Wales, Northern Ireland and Scotland if they could send us the basic identifiers from all the patients who'd had a positive COVID swab, along with the date of the swab and their treatment modality. And there was a phenomenal response to that, such that we now get data from 49 out of the 51 renal centres in England. Through the Scottish Renal Registry, we get all the Scottish units, Northern Ireland, and 4 out of 5 in Wales. So the data in these 2 panels is the same data. It's on the left, as you would look at it, it includes London, and on the right panel, it is the same data, but with London excluded. For quite a lot of this talk, I'm going to talk about in-centre haemodialysis patients, and that's not trying to exclude the other groups of dialysis patients, but it's merely that we think we have much greater confidence that we know what is going on in that group of people because of a more reliable swabbing practice. So what did we find? So this is between the 8th of April and last week, the 29th of April. And the gentle points would be twofold, really. The first is that London, and then in light blue, the West Midlands had significantly more cases, then followed by the Northwest in dark blue. And that in all cases, the cumulative number of cases is slowing down. And just like, I think a lot about the fact that this is just like the BBC News at night, and the only caveat to a sentence like that is just as they would do to acknowledge that the last data point on these graphs is always less certain because of a delay in the reporting of data to us. In contrast, so this represents 2,100 in-centre haemodialysis patients. There were far fewer home hemo and PD patients, in total 123. Okay, so this is probably the most, pretty much the only data-rich slide actually in the whole presentation. And this is going to attempt to describe what has happened in the different dialysis populations in the different regions of the country. So if we start with England, which is the fourth row from the bottom, the first column describes that there were 21,500 odd people doing hemodialysis in England at the last point that the registry knows with certain exactly how many people there were. That's the 31st December 2018. And at the same time, there were approximately 3,100 people on PD. Now, as we've already talked about, so if there were at this point, slightly fewer than 2,000 in-centre haemodialysis patients with a positive COVID swab, that represents 9% of the population overall at that point. And of the PD patients, that represented 2.9% of the 3,100 patients who we knew about. Now, it is worthwhile pointing out at this point that there is an intrinsic difficulty in comparing the rates or the proportion of the populations infected in these two groups. Because whilst I could be fairly confident that an in-centre haemodialysis patient, when they attend for their dialysis, would be asked questions about their symptoms and swabbed if they had any suggestion of a corona-like illness, I'd be less confident that a PD patient would have the same opportunities for swabbing. And therefore, again, just like the BBC News, we rely instead on the proportion of the in-centre haemodialysis population who died. In this case, forgive me, that is 1.8%, and of the PD programme, 1.1%. The overall message I would take from those two is not dissimilar to Gareth's, actually, that I would quietly hope that although the two populations are not exactly the same, that nonetheless there would seem to be an advantage to being able to shield comprehensively, which is accessible to the home therapies patients, but less so the in-centre patients. In general, there was a lower proportion of the population affected in the home countries, and then across the counties of England, as we would all recognise, a greater proportion of the population affected in London, followed by the West Midlands, and then other areas. Okay, so what else do we know at this stage about the way that it has affected particularly in-centre haemodialysis patients? So we know that the age and gender distribution is similar for those with a positive, reported to us with a positive swab result compared to the in-centre haemodialysis population as a whole. There's a suggestion well, no, that's not correct. It is factually correct that South Asian and Black patients are overrepresented in the cohort of patients reported to us with a positive COVID swab. But that may very well represent a difference in the different regions that have been affected by COVID, which we know, this slide taken from the UK Renal Registry data portal, which shows the ethnic variation in renal replacement populations in London, where it's a minority white population of about 40% in the West Midlands, which is, of course, where the majority of the COVID cases have currently come from. So, I beg your pardon, going backwards. We do know that the crude, so that's the unadjusted 7 and 14-day survival for in-centre haemodialysis patients following a positive COVID swab is 89 and 81%. That would have a mortality rate of 11 and 19% at 7 and 14 days. We know that the absolute risk of dying increases with age, but the relative risk of dying compared to the general population is higher to younger age. And actually, I think that many of the audience would agree. I could say that about lots of conditions affecting men and women with end-stage kidney disease, that is, the absolute risk is higher in the old, but the relative risk is higher in the younger. And the other important fact is that at the point that this data was analysed, there was no statistically significant difference in mortality either with ethnicity or with deprivation. So finally, as my final slide, I wanted to, as well as thanking the centres for their phenomenal effort in returning the data each week, I also wanted to thank people for helping us with the other cornerstone to the way that we're going to collect and report data. And that is to accelerate the return of the data to us to identify that's the normal quarterly data which the units would send to us, have been sending us now for 25 years, such that we could generate a cohort of patients at risk on the 31st December 2019 that we could then follow through the coming months as the population at risk of coronavirus infection. So we have the statutory permissions and indeed willingness from Public Health England, ICNARC, and through a collaboration with the Getting It Right First Time programme, the Secondary Users Service Hospital Episode Statistics. And using those data linkage, we were going to focus on three priorities. The first is to check that the data that you have been kindly sending us each week is an appropriate representation of the positive swabs in the population as a whole, and that's particularly relevant to the second point about home hemodialysis and transplant patients, in whom will give us much greater confidence that we have detected the cases. And then the third point, which plays to the points that Chris and Claire were making, is to better understand the rates of infection and indeed outcomes of patients with end-stage kidney disease admitted to ITU. And the final point, because as again, I think many of you would reflect on over this weekend, nothing stands still. And that would be true of the data collection that we've been doing the last 6 weeks too. And the 2 points would be that if we are going to make sense of any change in rates of infection going forwards, we think that we're likely to need some measures of the practice patterns that people have adopted and perhaps are going to relax over the coming weeks in order to identify which of those appear to be related to an increase in infection. That would be point number one. And the second is that even our swabbing practice isn't static, and that in the coming weeks and months, it's very likely that we will be getting into asymptomatic testing of individuals, first by antigen and then by antibody testing, and that we're going to need to reflect that in our data collection and analysis. With which point, Indy, I was going to hand back to you. Thank you very much.
So Thomas, you know, everyone knows Thomas. Thomas is a clinical trialist and a trials methodologist with the Cambridge Trials Unit, and is honorary nephrologist in Cambridge. And he's also jointly leads the UK Renal Trials Network. And Thomas will take us through research in COVID-19 patients, mainly in relation to renal disease and renal patients. Over to you, Thomas.
Great, thanks very much for the introduction, Indy, and thanks for the opportunity. I'm going to talk mostly about trials. It's been an absolutely crazy time for people who do trials over the last few weeks, as it has for most other things, and it has been quite hard to keep track of exactly what is going on, what is happening, and things have been moving really very rapidly indeed. In trials that take typically 18 months to set up have gotten up and running within a matter of weeks. I thought what might be most useful is to start with an appraisal of what the current landscape looks like. It has been quite a challenge for me to keep on top of things, and I've made an attempt here just to try and summarize the prioritized studies that are either currently active and recruiting, and or those that are imminently starting, and some reference to how that relates to renal population. So from left to right on the table there, the recovery trial is probably the best known of all of these. So it is enrolling patients who are COVID-19 positive or strongly suspected to be positive in secondary care, and is a multi-arm adaptive trial assessing a number of interventions, which includes antivirals, hydroxychloroquine, steroid, and azithromycin. As things stand, and as most people know, it's approaching 10,000 recruits, which is just staggering. It's I think, unprecedented. The in-trial follow-up duration is 28 days for recovery, and the outcomes include things like death, time to discharge, ventilator dependency, and also renal replacement therapy at 28 days. Recovery will allow a recruitment of patients with kidney disease, and that's an important point to make. So recovery will provide some evidence for us for patients with impaired kidney function, although of course there are judgments to be made by PIs as to whether they feel patients should or shouldn't go into the trial, and that relates to the interventions as well. So for hydroxychloroquine, for example, clinicians might not put patients into that trial with the sort of doses that are being proposed if there is advanced renal function impairment. So that's recovery. Principle is a primary care trial, again led by the Oxford group, intending to enroll at least 3,000 patients. This is aimed at those over the age of 50 with comorbidity, or over the age of 65, even in the absence of comorbidity, and is a treatment trial using currently hydroxychloroquine. There may be additional interventions introduced. And the entry for Principle requires a confirmed diagnosis of COVID-19 or a suspected diagnosis. So people have to be symptomatic and suspected of having COVID-19 to get into Principle. Principle will allow a GFR up to 30 to go into the trial, but below 30 patients are ineligible for Principle. Then REMAP-CAP, the next one along, is an intensive care trial, again multi-arm adaptive trial, and is a global trial. The former two are UK only trials. REMAP-CAP is currently recruiting as a global trial, looking at various domains. So it's an oversimplified representation here. 90-day follow-up. And will permit folk with impaired kidney function to go into that trial. COPCOV briefly is with the IFA slightly greyed out there because it's not yet recruiting, but this is an international trial of prophylaxis with hydroxychloroquine in healthcare workers. Will include healthcare workers with impaired kidney function down to GFR of 10. The Oxford vaccine trial is currently in phase 1, and probably don't need to say more about that. COVACTA is a trial of tocilizumab, which has 60-day follow-up and is, I think, single center, or I'm not entirely sure, of that, aiming to enroll 300 patients, a smallish trial with in severe COVID-19. Accord has been in the news over the last couple of days. It is a new platform. It's not really a trial as such, but a platform to allow multiple nested trials that is set up by Southampton and is a government initiative. The first randomization is listed as being active, but it's not yet recruiting, and that would be a placebo-controlled berncentinib trial. So I haven't been able to access the protocol. I don't have any details, but the idea is that Accord will allow early phase of sort of proof of concept assessment rapidly of multiple compounds, which will then, once they graduate from this platform, be kicked into some of the larger trials, right, like Recovery or Principle. A similar concept is Tactic-R, which is a platform that will allow multiple interventions to be assessed. This is also nationally prioritized, but not yet quite made it onto the portal. And I think the plan is to start recruitment tomorrow. There'll be 2 interventions. These are immune modulatory, baricitinib and ravulizumab, with the outcome shown there. And down to a GFR of 30. So again, for milder chronic kidney disease, will provide us with some evidence for patients with CKD. And then finally, unfortunately, the bit that says talking, Dr. Thomas Eamstra, is overlying that column, but I think that might be hiding prolific, which is another UK-only healthcare worker prophylaxis trial of hydroxychloroquine, which will start in the next week or so, as I understand it, and will enroll healthcare workers, particularly from high-risk areas, so intensive care, emergency medicine. So that's the landscape. There are, I'm sure, other studies that I've missed. I'm aware of some early phase, very small studies that are on the national prioritization list that I haven't listed here, and there may well be others that are not nationally prioritized that are ongoing. So if you're running a study and I haven't mentioned you, please don't take it personally. I think this is a very rapidly evolving space. So for kidney-specific things, there are really just two projects that I wanted to mention briefly. The first is not a trial, it's an observational study called Beat Corona, which is not yet enrolling, will probably start up in the next couple of weeks or so. The idea is that this is a comprehensive cohort study that will allow at scale patients with kidney disease or autoimmune disease or inflammatory bowel disease to enroll using an online portal with an associated smartphone app that allows them to create a profile, provide some information about their healthcare, consent to participation, consent to linkage with PHE and NHS Digital and related data sets, and importantly, consent to approach for other research studies, including trials. So that's the comprehensive cohort concept. It should serve then as a tool to allow rapid recruitment into randomized trials of relevance, and it should also allow us to conduct some robust epidemiological studies. The other half of Beat Corona is a healthcare worker study, so again would be observational at scale, allowing healthcare workers similarly to create a profile and to consent to approach for research, which would include trials like Prolific, which is the hydroxychloroquine prophylaxis trial. So simple concept observational study. These are just some snapshots of what the Beat Corona app will look like. The reason I mention this is that it is relevant to the next study that I will tell you about briefly, which is a new trial called Protect, which is a kidney trial. It's supported by the UK Kidney Research Consortium. It is now funded and in the final stages of approval and setup. So briefly, Protect is an open label trial of hydroxychloroquine versus standard care in the first instance. It's a basket trial design, which means that we will enroll a number of distinct populations, and each of those populations will be independently powered, but there will be some adaptive approaches to the analysis, which allows us to borrow events between patient groups. So the first patient group that will start up is in-center dialysis for the reasons that James and others have alluded to, that they are at highest risk and of course can't self-isolate. But transplant and vasculitis and autoimmune disease arms, as it were, are at an advanced stage as well, and will start pretty shortly afterwards over the next few weeks, we hope. So the idea is that we can harmonize as many things as possible between these populations. The key difference between dialysis and non-dialysis populations is that face-to-face approach for enrollment will take place for the in-center dialysis patients, but for the other cohorts that are not attending hospital, consent will be online and remote, and so there will be no study visits. The hydroxychloroquine will be mailed out to patients. And all of the follow-up will again be remote via online or smartphone app methods. There are, of course, differences in dosing strategies between dialysis and non-dialysis patients, given the implications of advanced renal function and clearance of hydroxychloroquine. So for PROTECT, the dialysis population will hopefully start recruiting in the next couple of weeks. The inclusions, these will be adult dialysis patients on in-center hemodialysis, and it will be a pragmatic design, but there are some exclusions of note, so prolonged QT, for example, and retinopathy and insulin dependent diabetes or type 2 diabetics taking insulin would be excluded. The design is fairly straightforward. It's a two-way randomization that will be stratified by center, by age, and such. So the objective is to enroll 500 in-center dialysis patients, and the treatment duration would be up to 6 months. What I may not have said, which is important, is that this is a prophylaxis trial. So it's not a treatment trial. We will be able to get some evidence from trials such as recovery. This is a prophylaxis trial, and if patients come to the end of participation in this trial, then they would be eligible for recruitment into some of the other treatment trials. The primary outcome for PROTECT will be the time to COVID-19 positive diagnosis. With that, I think I will stop. If anyone is interested in participating in this trial, many of you have been in touch already, I know. There's an email address there. The only other thing I would say about this is that it has been an absolutely enormous effort. There have been in excess of 50 people, many on this call, working on this proposal. And it has been a terrific experience to see how everyone's pulled together. In any event, I will stop there. Thanks very much, Indy, and I'll hand back to you.
So we'll start the next part of this webinar, which is the panel discussion, and we'll start with a very short presentation from Fiona without slides on the patient's perspective, of the COVID-19 epidemic in the UK. Fiona.
Thank you, Indy, and thanks to the Renal Association for the chance to talk about the patient experience, which has been unprecedented. It's been like a very unpleasant fairground ride, which has twisted and turned, and we haven't been able to get off. And I know many of you haven't been able to either. So just to start with some of the direct consequences, this won't be a surprise to hear, but the primary sort of response we started to hear from kidney patients was around fear. So a huge fear, a fear of the infection, a fear of dying, and just not knowing what's going to happen next. Alongside that, there's been just the questions like, how can I get tested? Does a test hurt? And then the sadness for people at losing friends who suddenly have disappeared from the dialysis unit, and how to kind of deal with that while at the same time trying to comprehend and manage yourself in this situation. There's been confusion about messages, and many of you will know about the message about people shielding. What does shielding mean, and who should shield? So for a long time, people on dialysis didn't know that they should shield, and now they know that they should. Some of them know that they should, but we think there has been some harm to some of those people, and the impact of that has been that people have had to go out and get their shopping themselves, and there are still people who haven't had the information that they need to shield away and are still queuing outside supermarkets to be able to get food. Food has been a really big theme through this. It's kind of one of the more indirect things as a result of the shielding and self-isolation, people trying to get hold of food in a way that is safe. So the government food boxes have come through the shielding programme, but as I've already mentioned, some people haven't been able to get food at all, and we've heard an awful lot about that, and that anxiety still continues. There's also, alongside some of those that confusion about messages, there's been something about, will I get access to intensive care? So if I get ill, what's going to happen? Will I be able to get hold of will I be able to be treated with a ventilator? We've had loads and loads of questions about that as well. And some people have had requests to look at what's their view on do not be resuscitated, and that's come up quite a lot of times as well. So those things have come together in this sort of mixture that keeps hitting people and changing from day to day. So if we talk about some of the further consequences of that, you won't be surprised to hear me talk about mental health. So I think that the mental health consequences of this are going to be very, very long term. So the self-isolation, there are many people who haven't literally stepped outside their door for the last 7 weeks. This isolation has affected different people differently. So some people, if you live in a house, I live in a house with a garden, so I've been able to go outside, but others live in the middle of a city and they're not able to do that. So not everybody has experienced it in exactly the same way. By now, boredom has started to kick in, and alongside the anxiety, some anger as well, anger with the system, anger at the situation. So that's something that's starting to develop. We've also got the impact of those lost opportunities around cancelled transplantation, and I know Gareth talked about that very clearly before, but for people who've had to now start dialysis and deal with that at the same time, that has been difficult. And then we've got pressure on carers and families as well. So should they be self-isolating? What do? Do they continue to go to work? Can they afford not to go to work? And we know that there are people whose employers haven't perhaps supported them as well as they can, and a number of people have lost their jobs already. So we've got income issues as well that we're hearing about at the charity in terms of requests for grants and so forth. Then we've got the thing about less surveillance. So obviously, for very good reasons, COVID became an absolute priority. But behind that, there have been many people who've had their blood tests, their regular surveillance postponed. And the kinds of worries we're now starting to hear are people who are wondering how to get safely back to their blood tests, wondering about those non-urgent treatments that actually now may become urgent, and wanting to see that the NHS is there for them as well. And they know that, but at the same time, we've still got this reluctance in people going to hospital, and also knowing that it's safe for them to go and have their blood test, and being very patchy, mixed messages there. There've been some really positive stories as well, and people have really, really appreciated the incredibly hard work that you've all been doing for them, but I just felt it was worth sharing that too. And there's been a very strong thirst for accurate information, for good information. So, we know about misinformation being around there, and people are over-focusing sometimes on media and those messages out there. So we've been really grateful for many of the colleagues on here today to working with us to produce patient information probably every day for the last 7 weeks, not the weekends always anyway. Have we updated that patient information there and tried to turn it, and James knows this very well, and tried to turn it into something that everybody can understand. So as an example, I think the first 3 weeks of March, we had 250,000 hits on that page of our website. So it gives you an idea of the sort of thing that people were seeking and trying to find out. And I think that the need for reassurance, the need to understand the long-term impact of this, and the kindness that you are all going to be giving those patients is going to be very, very important as we go on with this. And we have to also think about what happens next. So shielding is likely to go on, and the impact of that, and how you deal and advise your patients and help them to make a sort of informed and shared decision on what their choices need to be about having a transplant, about maybe some of them going back to work, and how we can manage ourselves and manage that as we go through. And I think the chance to learn from all of this, and for you and us to be able to advise your patients as to what treatment choices they might want to make over the rest of 2020, given that the pandemic is still going on, will be incredibly helpful. So it's great to learn and be able to share that information. So I think I'll stop there and say thank you very much, and hand back to Indy, because there's more I could say, but...
That's fine. Thanks, Fiona. Great. I mean, it's, as always, very good overview. And I think you've answered a question, that pre-submitted question from Nicola Thomas about support, and which I think you have addressed more or less. So I wouldn't put that question again to you. I'll now ask Karen Jenkins, Karen, to say a few words, because, as you know, our renal nursing staff have been under enormous pressure over this period through increased workload and also through staff sickness. So, Karen, would you please say a few words? from nursing perspective.
Yeah. Thank you very much, Indy. I think there has been a huge pressure on the nursing workforce in all areas, I think, of renal nursing. We've been looking at how we can upskill our specialist nurses into dialysis. I think Gareth alluded to that earlier. I think trying to work collaboratively with our intensive care units as well to be able to support giving intermittent dialysis and different treatments, trying to put together training programs. I think a lot of the concerns, I think, on the nursing side have been about trying to manage with the issues around PPE has been a big question because it's been changing, the advice has been changing. And I was quite interested when Gareth said they had such a high percentage of staff sickness in one satellite unit. And I was just wondering if that was related to the PPE or just if there happened to be a cluster outbreak. So I think there's been a lot of challenges for the nursing staff and trying to pull together to manage in this very, very difficult time. And we've been incredibly fortunate to, I think, being creative with the workforce to see how we can upskill other people, even with lining primary machines, getting medical students in, dietitians in. There's been a lot of shared experience of getting people involved, and people have really stepped up to the plate. So I think there's a huge praise for the fact that the nursing workforce has worked extremely hard together to try and keep things as safe as possible for our kidney patients. So I'll stop there.
Great. Thanks very much. Yeah, very, very comprehensive. Thank you. I know it's a very short time, but yeah, thanks very much. So now we'll take a few questions. Now we've got a long list of questions already, so we'll try and take some of those without overrunning too much. One question that we have from Vincent C. is about, should young adults under the age of 40 and children who are at much lower risk, according to UKRR, be unshielded for their mental health and allowed to go back to work? Who will take that question?
I'll start if you like.
Yeah, I mean, very, very briefly though, yeah.
Yeah, really briefly, it's got to be an individualized decision made between that clinician and the family and the patient themselves, so they could understand their risks and look at what they can do to keep themselves safe, because this may well be their chance to finish their education and to make their careers as well. So it's something that will affect the rest of their lives, but it has to be a personalized decision.
Sure, thank you. Thanks, Fiona. Next, we have a question from Charlie Thompson about high rate of markers of glomerular and tubular function is interesting. Does urinalysis change management or help to predict outcome? Chris.
Thank you, Charlie. So I don't think we fully understand what is driving the abnormal urinalysis rates. There are clearly, we would suppose, a small cohort of patients who have glomerular disease. Is there any tubulointerstitial inflammation driving some of this proteinuria and hematuria where it's low grade? A lot of this is not nephrotic range or associated with nephrotic syndrome. Is there any microvascular component to this? So I think it's not well understood outside of the biopsy findings and post-mortem findings that we've found. Obviously, in normal viral infections, it would trigger discussion around renal biopsy and antiviral therapy. This is not a therapy that is available to us, but certainly should those therapies become available, then I think this would become something that more directly influences management.
Thanks, Chris. The next question I think we will take is from a patient, John Coop. I'm a 50-year-old kidney transplant patient with stable graft function, 15 years post-transplant, no underlying medical conditions. Will I be able to return to work with strict social distancing after 12 weeks? What's the advice to my family returning to work, school, etc.? It will be very difficult to be separated. Gareth.
I think that's a difficult question, and we will await the advice that is hopefully coming out this weekend and then on from there. I think we will also have to see what happens when you say that we've past the peak of the pandemic? I'm not sure that we have. And there may well be further spikes. And I think as lockdown is lifted, you may well see further spikes. If that is the case, I'm sure that the government will then say that people need to shield for longer. If it's the fact that we don't see further spikes, that advice may well change. But I completely agree. It's incredibly difficult. So as we're doing our clinics virtually, phoning around our patients and saying, how are you getting on? That is the most common thing, is that people are stuck at home and they want to get back to normal life. And they certainly, when this started, people looking at 12 weeks have been stuck indoors. There are all sorts of issues for people's mental health. So I can't really answer that question directly without knowing what's going to happen.
And a related question from another patient, Kirit Modi. It's how is this risk explained to patients?
The risk from...
He's a transplant patient, so I suspect it's a question too.
I know, Kirit. So I think there's quite a lot of advice that has been put up both on government websites. I know the Kidney Care UK website has some excellent advice there as well. I think giving people exact numbers is very difficult, and I think that we're only now getting that data that is specific to dialysis and transplant patients. So hopefully now we will be able to tell people a little bit more and give them a little bit more directed information about that.
Thanks very much. The next question, I think, is for Claire from Jeremy Levy. Any data from ICNARC on outcome from ITU of patients admitted with pre-existing end-stage renal failure on dialysis, i.e. our dialysis transplant population, Claire?
No, there isn't. They don't. The granularity of the data doesn't come down to that. So they do talk about people with pre-existing renal disease, but you couldn't pull out from the ICNAR data dialysis or transplant patients. So I think over time, people are gathering that information, certainly step downs from ICU. Lots of people are looking into both the AKI and patients who've had gone into ICU with end-stage kidney disease, what their outcomes will be. But I think it's a little bit too early for us to report back on that yet.
Excellent, thank you. There's a question to Thomas for the PROTECT trial. How do you know if we have had COVID-19 already? If they have had COVID-19 already, are you doing antibody tests prior to inclusion?
That's a great question. We are not, is the answer, doing antibody testing. So if someone has had a test or they have been symptomatic between the 1st of March and the approach date, so symptoms suggestive of COVID, they should not go into the trial. But we are not screening for those people who might have been asymptomatic and have had COVID-19. Of course, things are changing very quickly, and the situation now is different from what it was 4 weeks ago when this trial was designed. Others have alluded to the fact that we will probably be moving to testing. Some centres I know are doing that already of dialysis populations. I don't think that's a bad thing. I don't think it has an impact on the trial as such. It'd be helpful to know whether someone has had the infection prior to going into the trial. But PROTECT is not proposing to screen people for COVID-19 before going into the trial, providing they haven't had a confirmed diagnosis.
Thank you. There's another question related to nursing and medical teams. Is there a plan for support to nursing and medical teams emotionally post-pandemic? Now, I'm not sure who is the best qualified person to answer this question. Shall I ask Claire, do you want to take this one?
So just repeat it for me again, Indy, sorry.
Is there a plan to support nursing and medical teams emotionally post-pandemic?
I'm sure every trust had. So I can only speak from our own trust perspective, and we have put in place a wellbeing program to try and support staff during the pandemic, and certainly ongoing. That there's been, actually, I've been quite impressed with the support processes that have been put in place, and I think that's going to evolve over time, as long as we have social distancing, and as long as we have a sort of that fear that is there for everybody. I think if support processes are important, and we will have to see how they pan out over time. I don't know if Karen has any experience of them.
Karen.
Yeah, thanks, Claire. I think you're right. Most trusts are putting something in place with wellbeing, but I think having recently set up a lead nurse WhatsApp group and actually being able to share experiences and supporting each other, I think that's been really, really helpful to sort of have that in real-time support. And going forward, I think that's something we can look at, whether we have something. You can't do something nationally because each trust has a different approach to something. But I think it's making sure that people have got an awareness for health and wellbeing, and we do have something in place, and maybe we can share experiences, whether that's, you know, through this kind of a webinar or through the K-Quip and the regional networks. I think sharing experience through the regional networks has been hugely important in this current climate, and it's been a great way of actually supporting each other. So I think it's just keeping it on the agenda very much. I think staff wellbeing is hugely important, because that ensures patient wellbeing as well.
Thank you, thank you, Karen. The next question is for Fiona from Liz Lightstone. There were delays with shielding letters to certain groups of patients, and I've seen confusion about when did the 12-week start. What advice are you giving, Fiona?
Thank you. Yeah, so we asked the Department of Health and Social Care about this, and they have told us it's to the end of June. Obviously, that's subject to change. But in Wales, we asked the Welsh Government, and apparently it's the 15th of June in Wales, and they confirmed that. So that's the answer, and we'll see what happens next.
That's great. Thank you. Thanks very much. And the last question, perhaps, from Rebecca Suckling. Should we not be, I think it's for Thomas, should we not be offering online recruitment to hemodialysis patients in satellite, as we are trying to avoid excess appointments and are remotely reviewing these patients?
Yes, good question. So the online methods will also be available for dialysis patients.
Great. Thank you very much. I think we're nearly 6:15. We've overrun 15 minutes, which was planned. And I'm sure you will agree that it's been an absorbing hour and quarter of excellent expositions and discussion on COVID-19 and kidney disease. But I'm afraid it is time for us to close the session. And many thanks to all our speakers and panelists, and also to you, the audience, the attendees. I hope you've enjoyed it as much as I have done. Have a good evening all. Thank you again.